The subject of abortion is an incredibly emotive topic, which has to be researched and covered in a very sensitive way. So, rather than using sensationalist language and taking a pro-life or pro-choice stance, I've decided to simply present the scientific facts as they are currently understood. This should help you on the way to starting your own research and building your own opinion. I have to point out that the included training and procedure video clips may be disturbing to some viewers. I'll notify you immediately prior to these clips, so that you can make an informed choice. This report presents statistics on abortions carried out in England and Wales in 2013. The total number of abortions was 185,331. This was a 0.1% more than in 2012, which was 185,122, and 2.1% more than in 2003, which was 181,582. So, what procedure can women expect to undergo in a Western medical abortion? The following videos are instructional and are produced for medical practitioners. Whilst dolls and mannequins are used, the procedure and instructors are genuine. Firstly, an early termination within the first trimester.
What we're now going to do is we're actually going to demonstrate the techniques of surgical abortion in all 3 trimesters. The first demonstration we're going to do is the most common type of an abortion. That's the first trimester suction D&C. For illustration purposes, we have this black cloth up here, which is going to represent our operative field and where we'd be working. Just so you know ahead of time, you're not going to see any blood, you're not going to see any baby parts. What you're going to see is the reality of what an abortion actually is, and you'll be able to put what I'm doing together with the images that you've already seen of the babies at the different stages of development on the inside. But the first demonstration is for the first trimester abortion. So this would be done anywhere between 5 weeks and 12 weeks. This is a speculum. The speculum is what is going to let us see the cervix, which is the lowest part of the womb. So the speculum would be placed on the inside. It would then be opened up by the abortionist and would be used to actually look at the cervix. The cervix only has one job, and the job of the cervix is to stay closed until the mom gets to term, and then the cervix would start to open, and then the baby would be delivered. So in order for the first trimester abortion to be performed, first the cervix has to be seen, which is with the speculum, and then the cervix needs to be stabilized and grabbed. This is a single tooth tenaculum. You can see the points there at the end are sharp. This would be placed to the inside, and the cervix would then be grabbed and could be held and could be controlled. Once the abortionist would have control of the cervix, now he has to start to open the cervix, a process called dilating. This is called a dilator. There's a whole series of about 10 or 12 of these that start off small like this, which are then passed through the opening of the cervix, and then it's flipped around to the larger size, and then it gets a little bit more open up until you go to a larger dilator like this. And depending on how far along the pregnancy is would determine how large you would have to get the cervix in order to remove the baby. But then this dilator would then open the cervix even a little bit more. Once the cervix has been opened, the womb is now open to the abortionist, and the baby has now lost its protection from the cervix. For the first trimester abortion, even though the baby has a heartbeat, fingers, toes, arms, and legs, it's not developed enough where it has real strong bones. So the baby, the placenta, the fluid, all of those products are actually removed with a suction device, which we'll also demonstrate. But the suction tubing is hooked up to a suction curette like this, or even smaller, depending on how far along the baby is. That suction curette is then placed through the speculum, up through the cervix, and actually up on the inside of the womb where the baby is. So this opening for the suction curette is then up where the baby, the fluid, and the placenta are. Once that is up by where the baby is, then the suction is turned on, and the baby, the placenta, and everything else are then brought down through this tubing over into the suction machine. Once that's finished, we talked a little bit about one of the complications being Asherman syndrome. This is a curette. You can see it's sharp on the edges, it's rounded, and the job of this is to actually scrape the lining of the uterus for whatever is left as far as little pieces of placenta and blood clot. So this is passed up in through the cervix, up into the womb, and then around all sides, all the remaining tissue is then scraped out. And then the procedure is finished. The speculum is then closed and is then removed, and then the first trimester abortion is then finished.
And in the second trimester?
The next technique we're going to demonstrate is for use of terminating a baby that would be in the second trimester. This would be a baby just like Samuel Armas. Remember we talked about how Samuel had had the surgery done on his spine when he was still inside the womb? Well, that's the gestational age when this procedure would be performed. This would be performed between about 13 and 23 weeks along. But again, the techniques for the beginning part are very, very similar. We use the speculum. Speculum is then placed on the inside in order to give visualization of the cervix. And because the role of the cervix is to keep the pregnancy on the inside, we have to use the single-tooth tenaculum to hold and control the cervix again. Then we start again with our dilators, like this one, starting small, working our way up to a larger dilator because these babies are further along. And sometimes we have to use something called a laminaria. And the abortionist would place a laminaria, which is a very thin, dried stick into the inside of the cervix, maybe the night before the abortion, which would then have time to swell, absorb moisture, and dilate the cervix even larger for a more advanced development baby. But then the next thing that's done is the baby is too far developed, the bones are too strong, the skull is too strong, all these developing limbs and growing parts of the baby are just too resilient and too strong to actually be sucked through a tubing. So this is what will then be done. This is called a dilatation and extract, or a D&E. I want you to look at this particular set of forceps. If you can see those teeth are kind of like shark's teeth. They all point backwards. The reason they point backwards is so when they grab something like my finger, I can pull pretty hard and it's not going to slip out. You can probably even see some of the little grooves that it left in my finger. What this particular forceps does is, with an ultrasound guidance, as this is being introduced up into the cervix and up into the womb, the abortionist would look up on the ultrasound machine and would be able to guide this instrument, and whatever they see first is what they would grab. And remember, the baby is still alive, baby can still feel pain, and the baby is just as far along as those pictures you saw of Samuel Armas when he was getting his spinal surgery. But this is then used to grab an arm or a leg, and then once a firm grip on that arm or that leg is obtained, literally that arm is pulled off of the baby's body, or that leg is pulled off the baby's body, and that will kill the baby. Then the ultrasound is used to guide this instrument to remove the abdominal cavity, the chest cavity, and sometimes the most resistant thing to the abortionist with the baby is actually the skull. And sometimes the skull is just too developed to actually bring out easily. So a forceps like this is used to guide up around the baby's skull, and then once it's grabbed with ultrasound guidance, this is then used to crush the baby's skull, and then that crushed skull can then be removed. Then the same suction would then be used to remove the placenta, which is going to be left there on the inside. And then once again, this will be used to scrape the lining of the uterus of all the other blood clot and things that would be remaining on the inside. The abortionist would then look at everything that he's brought out. He'd look in, actually would on a stand like this one over here, would take all the parts that he's brought out and literally reassemble the baby to make sure that there were two legs, there were two arms, there was the skull, there was the chest cavity, and the abdominal cavity. And once he's realized and reassembled the baby there on the outside, The abortionist then realizes that he's gotten all the parts out from the inside. And don't forget, not only can we see these babies really clearly on ultrasound, diagnose abnormalities on these babies on the ultrasound, but this is when we can also treat these abnormalities of these babies on the inside. Yet just because somebody chooses, a baby can be aborted and can be terminated at this second trimester gestational age.
And now a late-term third trimester abortion.
The next technique we're going to demonstrate is the partial birth abortion. Partial birth abortion is a term that we hear a lot about in the news, but I really can't believe that people really understand what it means. Otherwise, we would not allow this procedure to be performed anywhere, not only in this country, but in the world. But a partial birth abortion is performed when the baby is too far developed in order to either be sucked out with the suction curette or to be able to be dismembered and brought out piece by piece with this forceps. A partial birth abortion, or a D and X, is very similar to what it says. We're going to deliver the majority of the baby, and then before the baby's head is delivered, then we're going to actually kill the baby. Now, before the procedure would start, the cervix would have already received those things we talked about called laminaria. Those are the sticks that go into the cervix that would then swell overnight and would open up the cervix because we have a lot more baby to deliver. And this can be performed anywhere up to term because remember, Doe versus Bolton defined mother's health as physical, emotional, psychological, familial, and age. So as long as the physician under those definitions says mother's health is in jeopardy, this procedure can be performed. Now, using an ultrasound to guide, the cervix will be dilated, the speculum would already be in place to open things up, and then using the ultrasound as a guide, this instrument would be placed in the inside through the cervix and would then grab one of the baby's feet. Once that foot is grabbed with that tenaculum, that baby's foot is then brought to the outside. Once that first foot is brought to the outside, then the second foot would be brought to the outside. And then with traction, with a baby that is still alive, the baby would then have both legs delivered, would then have its belly delivered. Once the baby is brought further down, first one arm would be delivered. That would be rotated this way. And then the baby is rotated around the other way, and the second arm is delivered. Now, the entire baby from the neck down is now alive and in the abortionist's hands that's performing this procedure. The entire baby, including the head, are already out of the womb, beyond the cervix, and the only thing that's left on the inside of the mother is the baby's head, but that's only just inside the vagina. And baby is moving, baby is alive, baby is intact up to this point. But if the baby then delivers, it's then considered a live birth and the baby would have to go to the nursery. But before that's allowed to happen, this is when the abortion would actually kill the baby. And the way they do that is, if you remember from biology class, there's that connection between the brain and the spinal cord, and that opening at the base of the skull is called the foramen magnum. And that small hole with the baby moving and alive in one hand, a pair of scissors, these are called Metzenbaum scissors. These scissors are then placed into the base of the skull, and these scissors are then placed in through that foramen magnum up into the baby's brain and skull cavity. The scissors are then opened up, and then if that hasn't killed the baby, then one of the suction curettes is then placed through that same hole up into the baby's skull and brain. The suction is applied, and just how you saw how powerful that suction machine is, if it can crush the steel can, then it can definitely kill the baby there on the inside. Once the baby has then been killed and is no longer alive, then the remainder, which is just the baby's head, is then delivered, and the procedure is then completed for the delivery of the baby. Once the baby is delivered, though, then the only thing that's left is to deliver the placenta by just, again, scraping the placenta and bringing that down. So when you hear the term partial birth abortion, that's what's going on. A baby is being delivered the feet, the abdomen, the chest, the arms and the legs. The baby is then killed, and then once the baby is killed, then the remainder of the baby is allowed to be delivered. So that's partial birth abortion.
And now, statistics from the UK in 2013. These are taken from a summary of information from the abortion notification forms returned to the Chief Medical Officers of England and Wales. This was prepared by Abortion Statistics DH. The age standardised abortion rate was 15.9 per 1,000 resident women aged between 15 and 44. This was 0.8% lower than in 2012 and 4.7% lower than in 2003 at 16.7. The lowest rate for 16 years. The abortion rate was highest for women aged 22 at 30 per 1,000. The highest rate in 2012 was for women aged 21 at 31 per 1,000. The under 16 abortion rate was 2.6 per 1,000 women, and the under 18 rate was 11.7 per 1,000 women. Both lower than 2012, 3.0 and 12.8 per 1,000 women respectively. And in the year 2003, there were 3.9 and 18.2 per 1,000 women respectively. 98% of abortions were funded by the NHS. Of them, over half, 64%, took place in the independent sector under NHS contract, up from 62% in 2012. 91% of abortions were carried out at under 13 weeks gestation. 79% were at under 10 weeks compared to 77% in 2012 and 58% in 2003. Medical abortions accounted for 49% of the total. This was slightly higher than in 2012 at 48% and 17% in 2003. 2,732 abortions, 1%, were carried out under Ground E, risk that the child would be born handicapped. Non-residents. In 2013, there were 5,469 abortions for non-residents carried out in hospitals and clinics in England and Wales. There were 5,850 in 2012. The 2013 total is the lowest in any year since 1969. The Abortion Act of 1967, as amended by the Human Fertilisation and Embryology Act of 1990, permits termination of a pregnancy by a registered medical practitioner subject to certain conditions. Legal requirements apply to the certification and notification of abortion procedures. Within the terms of the Abortion Act, only a registered practitioner can terminate a pregnancy. The doctor taking responsibility for the procedure is legally required to notify the Chief Medical Officer, the CMO, of the abortion within 14 days of the termination, whether carried out in the NHS or on an improved independent sector place, and whether or not the woman is a UK resident. The Department of Health provides Form HSA-4 for this purpose. Further details are available on the gov.uk website. Except in an emergency, any treatment for the termination of pregnancy can only be carried out in an NHS hospital or in a place approved for the purpose by the Secretary of State. After 24 weeks gestation, the abortion can only be carried out in an NHS hospital though. Through contractual arrangements with clinical commissioning groups, the CCGs, some approved independent sector places perform NHS-funded abortions. A legally induced abortion must be certified by 2 registered medical practitioners as justified under one or more of the following grounds. A. The continuance of the pregnancy would involve risk to the life of the pregnant woman, greater than if the pregnancy were terminated. That's under the Abortion Act 1967, as amended, Section 1(1)(c). B. The termination is necessary to prevent grave permanent injury or to the physical or mental health of the pregnant woman, Section 1(1)(b). C. The pregnancy has not exceeded its 24th week, and that the continuance of the pregnancy would involve risk greater than if the pregnancy were terminated. of injury to the physical or mental health of the pregnant woman, section 11A. D. The pregnancy has not exceeded its 24th week, and that the continuance of the pregnancy would involve risk greater than if the pregnancy were terminated of the injury to the physical or mental health of any existing children of the family of the pregnant woman, section 11A. E. There is a substantial risk that if the child were born it would suffer from such physical or mental abnormalities as to be seriously handicapped, section 11D, or in an emergency certified by the operating practitioner as immediately necessary. F. To save the life of the pregnant woman, section 14. G. To prevent grave permanent injury to the physical or mental health of the pregnant woman, section 14. So those are the facts about abortion, and I hope you take this information and use it as a springboard into your own research.